May I request our next speaker, Dr. SUDHANK Bharti. He is from Bharti Eye Institute, Delhi, and he will be talking on managing complications and pearls to avoid the phakic lenses. And he is a phenomenal surgeon and excellent refractive surgeon with a long history of doing refractive procedure for last, I think, 30-35 years, and he has got enormous experience of using these lenses also. Yes, thanks a lot.
Thank you, Dr. Purendra, for giving me this opportunity to be here in the instruction course. And hello. What?
Regarding the development of cataract, one other issue was which has been stated is because of the flow of aqueous from behind the lens to the anterior chamber, in the anterior chamber was obstructed by this ICL. So there was this was one factor stated in the past, and but because of this newer Vision IOL with the centraflow design, this has been taken care of, and the chances of development of cataract are now minimized. So flow of aqueous is better now. Please welcome Dr. Partha. Please come. Take photograph with Dr. Partha and our speaker there. Welcome. I welcome Dr. Partha Viswas, although he is lead. Is your slide ready, sir? Dr. Bharti?
My slides are ready.
No, I mean your
connection is not.
You can do it on this side. Can you?
How do you counsel patients having halos because of this?
This is something which is a transient phenomena. What I tell the patient, like in this hall, in front of me, this microscope is there, so many others persons are sitting in front of me, but I am focusing at you. You are also focusing at me, otherwise so many things. So you just have to neglect and avoid that. And immediately these young patients are very, very intelligent, so they forget it, and then after that they don't complain. Your reply.
No, I mean, it's halos, like always, either the halos go away or the patient goes away. That happens everywhere. But all said and done, this is a definite problem for the simple reason, especially these young myopes, the pupil tends to dilate quite a lot. And you have lenses of just about 5.16 millimeter optics. That's the reason when we check the mesopic pupillary size in all these cases. If we find the mesopic pupil is very large, then we go ahead and custom make a slightly larger optic lens. So whenever the pupil dilates, especially in mesopic conditions, beyond the edge of the pupil, then edge of the optic of the lens, then the patient starts experiencing halos. So essentially, I tell them not to look for it. Often they start searching for the halos because they've seen it. I say, you ignore it, your brain will adapt to it. Most often they get convinced, but otherwise using alpha-gun, using pilocarpine, we'll avoid pilocarpine because many of these patients are high myopes. But the usual ways you do with multifocal lenses is the way you handle it.
It's there.
There are some patients who persistently complain.
But that number is very less.
Yeah,
And in Indian eyes, our pupil size is also not large.
So now Evo Plus,
Thank you.
Ramamurthy, Evo Plus is 7 millimeter pupil. It covers 7 millimeter of pupil.
6.
So it doesn't-
maybe
7.1.
at the corneal plane.
The Evo Plus goes up to 7 millimeter. So mostly we cannot blame the size of the pupil.
Sir,
for
you have to come to the talk because
I'll
3 presentations are left and we are short of time.
Okay. So my talk is on managing complications and pearls to avoid complications in the
Sir,
ICL, and this is how we mark the axis. Simply, I don't know, it works. Yeah, so simply what happens is that you may not use all your fancy devices and expensive techniques for 180 markings. You can just mark it with a pencil and can use the mobile for marking these, and you can just mark as to what kind of axis, wrong axis you have already marked, and take your 0 to 180 and then go forward and start putting the ICL. This is a simple ICL surgery for a routine practitioner. What I am trying to show here, just to show that axis marking is important, and I'll come back to certain other things. This is a 2-minute video. We have marked the axis, and then a couple of tips for the surgery. The first thing is, when you do a side port, don't go beyond the margin of the iris, even if when you have dilated pupil. Like Ramamurthy, you can use a dilation later on, but here I have dilated the pupil, and then I put xylocaine intracameral 1%. And once you put a xylocaine, then the surgery becomes absolutely painless for the patient. Then I put a viscoelastic, which is a normal HPMC or whatever you are getting, because it's easier to wash and can be washed from the behind the ICL very comfortably. And then I make the main port. This is another thing which I do, and this is, I make the main port later after I have inflated the anterior chamber, so that, and follow the corneal curvature. So with this, it is not possible to damage the ICL. Now another thing which I want to tell everyone is that I put a little bit of viscoelastic on the mouth of the vial, and then once you have taken the ICL out, you are taking out the ICL, and then you can see that it sticks to the sponge. Even if you turn it around, it will not fall. So these are a couple of things which I have learned over a period of 20, 22, 23 years of doing my ICLs. And then rest of the things are very routine. You put it like this, though in my, and another thing where I want to emphasize another thing is that you pull the, don't pull the ICL, just pull the cartridge away. So don't pull the ICL into the snout, pull the cartridge away, and then it is not very difficult. Only once you will fail in and may put a ICL upside down and on the reverse side, and that can cause a lot of glaucoma and eye pressure. So that's another factor where you are, and then the rest of the thing is as routine. Every one of you is doing that. It's not difficult. Just make sure that you don't touch the center of the ICL while rotating or making it go behind. This is the time, and I take out the viscoelastic from behind the lens, and then put the viscoelastic in front, so that the lens is sitting flat inside the AC, and there is no viscoelastic. As much of viscoelastic as possible is removed, and then you can rotate it comfortably. Couple of times, this is the time when you can injure the crystalline lens, when you are pushing it and your spatula slips down. So this is the time when you should be very, very careful, and then you can adjust the axis at the right point. These surgeries are all done under topical anesthesia and intracameral anesthesia. It's not only topical, as I have been, and then just at the end, I want to put the irrigation right at the hole in the central fenestration, and I do not press the posterior lip. I rather lift the upper lip. If you push the posterior lip, there is always a possibility that your iris can come out. If you do not push the posterior lip, it will not come out, it will remain like this. You just have to lift the lip. These are a couple of things which I thought maybe I'll show you, just because. So now complications are increased IOP and subsequently glaucoma. Increased IOP temporarily could be because of sizing, and glaucoma, as the lady asked earlier, it could be because of factors which are unknown to us before, or we have not investigated properly, like the synechia and peripheral things. So that for that gonioscopy and other things are very important. But increased IOP is a vault issue, and proper vault is very important. And for that, sizing of the ICL is very, very important. So other things are possible, other things are under correction or over correction, which is of course your examination things which are possible. It's very rare that you have done a refraction more than a couple of times and then your ICL will go wrong. And wrong axis and ICL rotation is also because of the sizing issues, and we have discussed sizing in the other talks. But sizing is very, very important, and we must take into consideration the AC depth, because something like the ICL will not be same for a AC depth of 2.8 or 3.0 or 3.4. In higher myopias, the AC depth is much higher, and then the ICL sizing will be accordingly adjusted. And also we have to imagine that we are putting the ICL in this sulcus to sulcus and not, white to white is slightly thing. The other thing is that cloudy cornea or detachment or infection, these are the surgical complications as in other surgeries. So this is the thing, while you're doing the surgery, you have to be very careful that you do not damage the endothelium. You've already investigated that there is nothing, no disease related to corneal endothelium before that, and retinal detachment and everything. You have to properly investigate the patient, do all the kind of investigation which you want to do for indirect ophthalmoscopy and lasers. I always do, even if there is a little bit of small hole or a lattice degeneration in a high myope, even in these cases I want to do a lattice also, I want to treat. And infection is of course a thing which is surgical thing which is very important. The halos, glare and double vision, as we were discussing earlier, it is majority of times we have found that it is because of the central fenestration. And this central fenestration is, if it is there, then you have to only counsel the patient. Nothing else works. You have to counsel again and again, and maybe the patient understands. But it's something which, as Ramamurthy said, either the glare goes or the patient goes. They will stay together for always. It doesn't happen. Now, sizing, a couple of things about sizing. White to white at 180, the two ways which I want to measure them is pentacam and caliper. And I do it with the caliper, I want to do it in the operation theatre with the anesthesia and patient lying down, and then 180 marking I've already done before. So with the caliper, 180 in the OT is the best way to measure, because when the patient is sitting, sometimes the patient is moving and then you're struggling, and then sometimes it is better to let the patient lie down peacefully and then do the caliper marking. It is the other thing which is important, it is white to white and not black to black. So that white to white marking is beyond black to black. So this is another thing which is very important for ultimate sizing or correct sizing of the ICL. So that is why I do a pentacam and a caliper. And sometimes I find that, but with my experience, and not only me, with my staff's experience, because we have been doing this for last 25 years, it is white to white manually seems to be a wonderful bet, though I do it with the pentacam as well. The other complications are additional surgery for a low vault patient, a cataract, high vault, a glaucoma, and rotation for toric ICL where it has rotated. In majority of patients where the toric ICL rotated, you have to consider doing, replacing it with another ICL, because in a normal circumstance, unless it is, has to be a undersized ICL before you go forward, and it will rotate only if there is undersizing of the ICL. Other thing is, a couple of things are there which are, they're beyond your control, like hemorrhage, inflammation, iridotomy complications when the iridotomy becomes larger in earlier cases, and in all those hyperopic cases where you have to do iridotomy in these cases. And I differ from other surgeons. I do not do a hyperopic ICL unless the AC depth is 3 millimeter and not 2.8. So for me, AC depth of 3 millimeter is the basic thing for the hyperopic ICL. And this toric ICL, I am just showing it because of the reason that this fenestration is a very important factor, and sometimes this is the biggest culprit in causing all kind of halos. Thank you, Purendra, for allowing me, and thank you, the audience, for listening peacefully for such a long time. Thank you.
Thanks a lot, Dr. Bharti. Just one question. Your choice of implantation is either hydro implantation or with visco, and what visco you use?
I